I am Dr. Anthony Levinson, and this is my colleague, Dr. Richard Sztramko from McMaster University and iGeriCare. We apologize for the technical issues that we were having with our live stream event. Thank you so much for staying with us. Poor Richard and I did 15 minutes, so we've had a good trial run through on the this 9th event where we're talking about the stages of dementia. Any absolute pearls of wisdom that we have are captured on video, but we're really pleased to be able to take some of your questions and go live, and we really appreciate you sticking with us for the 15 minutes while we sorted out our technical issue around the live stream. So today is our 9th live event, and we're really grateful to those of you who sent in some great questions and stories related to dementia and the stages of dementia. We will have an opportunity to try and address as many of those as we can during today's live event. We will probably try and go a little bit later if we need to, at least till maybe 2 o'clock, so we get the full 45 minutes in because of the technical glitch. So again, apologies about that. Thanks for staying with us. For those of you who have to leave early, a reminder that we will be posting a recording of today's video on the iGeriCare.ca/events page. So even if you do need to leave us at 1:45, you'll be able to catch the full recording in a couple of days when we post that. So Richard, let's maybe jump right to talking about the stages of dementia. And there's different formats that we sometimes use as clinicians. Maybe start off with, what do we mean by the stages of dementia?
So if we start from the beginning, to be diagnosed with a dementia, you need to have cognitive complaints, so difficulties with memory and thinking, which often include short-term memory difficulties, so forgetting events that have taken place or repeating questions, executive function, things like problem solving or multitasking, planning events, visual and spatial issues, so not being able to navigate well, problems with complex motor tasks, so praxis, or social cognitive problems, so being a little bit disinhibited. So you need some sort of complaint related to that that's impairing your day-to-day function. And so if we start in a mild, moderate, severe paradigm, people at the mild stage or early stages will complain of subtle changes to perhaps their memory or their executive function. They'll be able to do most of the things that they would be required to do day to day from a functional point of view, but they're not able to live functionally independently without others' help. So they may not be able to do their taxes anymore, but still may be able to do a few day-to-day kind of finance things, or they may not be able to cook complex meals, but they may be able to do some, toaster oven or microwavable meals or things like that. But they may have some insight into what they're dealing with at the time. Generally, there'll be some insight retained at earlier stages, and then they'll progress into more severe issues. So when you're in a moderate stage, you're requiring more help with the instrumental activities of daily living. So you might not be able to do your shopping or cooking at all. You might need reminders to do your medications and things of that nature. But generally, all the basic activities of daily living are still intact. So you're able to eat by yourself and walk around your apartment or your house, and your bowel and bladder function is generally intact. At the mid stage, you may notice some emergence of psychiatric behaviors or psychiatric symptoms rather. So, perhaps some anxiety or depression, some significant apathy, and potentially hallucinations or delusions. The symptoms can happen at any stage, but generally they do become more prevalent with most dementias, the more severe.
And actually that was one of the questions that came in, was whether the stages are the same between the different dementias. So we'll talk a bit about that, because absolutely there are certain types of dementias where you may see, prominent psychiatric symptoms earlier than other types. So in some cases you may see that early on in the disease course, and then in other dementias it might only be a middle or a late appearing.
Right. And then we'll arrive at a later stage where people are really having significant impairment. They're requiring support for all of their instrumental activities of daily living and probably even some of their basic activities. So they may require help bathing. They'll need cueing to eat. They won't remember to eat on their own. Some people may even need help walking at that stage. And definitely where people that have mild changes might forget what happened to them a day ago or might be vague on some of the details around events that have happened. People that have severe dementia might not remember what happened to them 30 minutes ago and will ask the same question again and again and again over short periods of time.
And I think one of the things that we often see in the later stages are some of the signs and symptoms that make it very difficult for caregivers to keep their loved one in the home. So you mentioned sort of bowel, bladder, toileting issues or incontinence, very challenging in terms of the care demands.
Mm-hmm.
And then some of the psychiatric or behavioral symptoms or responsive behaviors, if there's agitation or aggression or things like that, that can be very challenging for people to stay in the home. And those are usually seen in moderately severe or the later stages of dementias.
And it's challenging, I think, because even within the severe stage of dementia, you may have somebody at the earlier stages of a severe dementia where they're able to walk around and when they're getting agitated, they can move and be independently mobile, where at the very end stage of severe dementia, the more end of life stage, people are having difficulties swallowing their food because the brain helps to coordinate those activities. And so there may be feeding and malnutrition issues, as well as recurrent infections because people aren't moving around as much, or they're more likely to swallow food into their lungs and cause a pneumonia. So
one thing that I thought would be helpful is even talking about just to help draw out conceptually what is happening in the brain
mm-hmm.
and how that maps to stages. So as we've talked about before, there are many different kinds of dementia. I'm going to illustrate this with Alzheimer's disease, which is the most common cause of dementia. But I guess this is one of the things that people sometimes don't realize. This is referred to as preclinical. So the concept of preclinical means that some of the changes represented here in blue, some of the changes are happening to the brain before somebody is diagnosed with either mild cognitive impairment or an early stage of dementia. So in this model, what we think is going on is that changes are happening, cells are dying in particular parts of the brain. Maybe somebody's having very, very mild symptoms, signs, they're having problems finding names or things like that, but they're not necessarily getting diagnosed with a dementia. It's so-called preclinical. As the disease progresses, though, at some point, more parts of the brain are affected, causing more symptoms, and the person is losing their ability to function independently. And so at this point, they're being labeled with a diagnosis of an early stage dementia. And as we talked about, the symptoms that they manifest, like memory problems or language problems, more symptoms become more severe. So the memory problems begin to really impair function. And then new symptoms may also appear as new parts of the brain become affected. And then in the more severe stages, you have widespread areas of the brain that are affected, many more cognitive functions that might be disturbed, and other symptoms like incontinence or behavioral symptoms that make it impossible for the person's level of function becomes much, much worse. So that's while it may differ a little bit by disorder, fundamentally what we are seeing is the movement from a healthy brain to a brain that might be atrophied or shrunken, where cells in different parts of the brain have died, or where toxic proteins or blood vessel damage have occurred, causing shrinkage and different symptoms. So I think that's kind of the model where people go from a preclinical state where the disease is starting to happen, but they have not yet developed enough symptoms to be given a diagnosis through to early stages, middle stages, and late stages. Do you want to say a few words just about the global deterioration scale, or the GDS? This is another way that people will sometimes stage dementia.
Sure. I think it's a more granular way of staging. It provides a little bit more separation and detail between different stages. So the GDS has 7 stages. So stage 1 is no cognitive decline. So the preclinical stages that you were just describing. Stage 2 is very mild cognitive decline, and that might corroborate with a diagnosis of mild cognitive impairment, depending on the degree of function. Stage 3 is mild cognitive decline. Stage 4 is moderate cognitive decline. Stage 5 is moderately severe cognitive decline. Stage 6 is severe cognitive decline. And stage 7 is very severe cognitive decline. So, we mentioned that even amongst severe dementia, you can separate it out a little bit more. And this is really helpful for research purposes. And each one of those stages can be tied to varying degrees of impairment on the functional metrics we talked about before.
All right, well, let's go to some of the questions, and then we'll maybe come back to talking a bit about some of the other stages if we have time. So here's a question. Do the stages differ across different types of dementia? So is stage 2 in Alzheimer's disease the same for, say, somebody with frontotemporal dementia?
Yeah. So the answer is yes, definitely. The different dementias look very differently. We've spoken frequently about how dementia is a umbrella term, or an unumbrella term, where you have different disease processes causing different symptoms. So a helpful lesson to check out if you have questions related to this is the different types of dementia. So, for example, in Alzheimer's disease, short-term memory deficits are really quite prominent, and the usual presenting symptom, we discussed these here, forgetting events or recollection of events is a little bit challenging. You may have mild word-finding difficulties with respect to language, so tip of the tongue phenomenon, or not being able to complete your sentences. And you may have some mild difficulties navigating in, let's say, unfamiliar environments. Whereas the initial symptoms of something like frontotemporal dementia, or a behavioral variant of a frontotemporal dementia, might be really significant, profound apathy, and they can still remember everything that they've been doing. So their short-term memory is intact, or they might be disinhibited and say inappropriate things, or they might become a little bit less warm from a personality point of view. So they lack empathy and will care a little bit less about their loved ones around them. So once you start telling that story of somebody who has a little bit of short-term memory difficulties versus somebody that's saying really rude or inappropriate things or becoming cold and uncaring, you can differentiate. And we do list all of the different symptoms that you could expect from the different dementias. And so early on, for those different dementias, you expect mild versions of those symptoms. And then as the disease progresses, you'll get more severe versions of those symptoms.
I think it might be fair to say that it's the mild, moderate, severe is a bit of an inexact science.
Absolutely.
That mild Alzheimer's disease would probably look a little different from mild frontotemporal dementia, but it kind of captures symptom severity and function at the same time with a bit of variability between diagnoses. But so there's some overlap, I guess, in terms of how severe the functional impairment is, but the range of symptoms might be different across the different dementias.
Absolutely.
Another question that came in, how long does it take to progress through the stages?
This is a really good question. And the answer is it depends. People are different. And so for some people to progress through the stages, you'd say an average of 7 to 8 years, but there are people that have Alzheimer's disease that progress quite quickly. much faster than that, within 2 years or so, or less. And then there are people that will lower than that. So what we generally will say is the rate of decline that you've been seeing will continue on, unless there's some intercurrent event that takes place that changes things, like a really poor hospitalization where you stayed in the intensive care unit or something. But generally, it's a fairly consistent rate of decline.
We've also talked about certain types of dementias like vascular dementia, where you might have a stepwise decline depending on if you have stroke or stroke-like episodes. That might cause a progression related to a vascular event. So.
But generally, that's definitely true. Generally, things do progress slowly. If you see a rapid change in cognition, then we worry about delirium.
Yeah.
And then we also worry about a different list of conditions that can cause a rapidly progressive dementia. So we take rapid declines in cognition very, very seriously.
Yeah, for the most part, dementia is typically a slower, more progressive deterioration. Here's another question. At what stage do you start to see personality and behavior changes? And I think we've talked a little bit about this, that you might see it earlier in certain types of dementia, like frontotemporal dementias. But in general, I guess personality and behavioral changes for many of the dementias are more of a mid-stage, middle stage. For certain dementias, like the dementia in Huntington's disease, that's another one where we often see personality change prior to the diagnosis of the cognitive decline. Any other comments about that in terms of personality?
No, I think you've captured that really well. One thing people will complain about will be emotional reactivity, sometimes a little bit earlier. So not frank, disinhibited, angry outbursts, but just
irritability.
Well, more irritable, and people would normally have the capacity to roll with the punches or deal with what's happening, and you'd give them the same set of circumstances, and before they may have been mildly upset, and now they're just more upset than they would be, or they have a temper.
Taking things
earlier,
taking things personally. I've seen
taking
people
offense,
who also respond very emotionally to certain commercials. There used to be that Coca-Cola polar bear commercial that a lot of people are emotional about, but people with early stages of dementia sometimes became very emotional over a stimulus like that. So
I think too, people might be sensitive around suggesting that they're having memory or thinking difficulties too. So if people are aware and have insight into it, they may get kind of more angry or reactive in that sense, and that might not be in keeping with their previous personality.
That's right. But
again, mild changes versus the more moderate and severe changes.
Here's a question from Ottawa. Following the diagnoses of an early dementia, and while the patient's fully aware of the diagnosis, are there ways to engage the patient in slowing down the process of moving to the advanced stages of dementia, both cognitive and physical? I guess that's sort of what can somebody do, and we have a lesson in iGeriCare around promoting brain health, and I guess the current state of knowledge around how one might slow the decline or the progression to stages would involve, staying active, staying socially engaged, eating relatively healthy in terms of doing whatever you can to manage blood vessel health, staying cognitively stimulated through social interaction. I'm not sure if there's anything else that we know of about slowing down the process of moving from one stage to another.
No, we've certainly tried, and if you check out our lesson on treatments of dementia, it does talk about disease-modifying therapy, where we've tried to get rid of toxic proteins or heal blood vessels, but we haven't been that successful. But exactly as Dr. Levinson has said, those general brain health principles are in play. It's not like we have a great trial where we've done all of those things and showed rigorously that there's true benefit, but we've had smaller trials in each one of those different areas. And if you're in the situation where you can't modify the disease, we do everything we can. I think the second part of the question was physical. You know, as people do progress throughout the different stages, they do tend to become more frail, especially if they have other medical conditions. Yeah. So staying physically fit definitely helps your brain and can improve scores on cognitive tests with respect to that, but also helps you stay more physically fit, able to function more independently, and certainly makes it easier on yourself as well as the family members caring for you.
Yeah, great points. Are there proven methods that would provide the patient, family members, or other caretakers in employing preventative measures to slow deterioration? I think we sort of addressed what the best evidence at the moment. So
I mean, on one hand, there's the slowing of the disease, and then there's the dealing with the consequences, and trying to avoid long-term care placement. So there are definitely structured interventions for family caregivers or friend caregivers that if you provide them with education, the person with dementia is less likely to go into a long-term care facility. So
here's a specific question: is having hydrocephalus, is that considered a dementia? And again, there's multiple different causes of hydrocephalus, which is sort of a condition where it's sometimes referred to as, you know, water on the brain. You can have something called normal pressure hydrocephalus, which in some cases can be a reversible cause of dementia. So it's very important to be assessed for whether you've newly developed hydrocephalus. And then there are some people who may be born with a genetic condition or other condition where they've had hydrocephalus as a child. And any type of brain condition or being born with a disorder like hydrocephalus can put somebody at increased risk for developing cognitive impairment or dementia. But so I guess as it stands now, people often do consider normal pressure hydrocephalus as a reversible cause of dementia, one of the things that would be important in terms of getting an assessment. Any other comments on?
I think that makes sense. I mean, the extra water on the brain could be caused by something more acutely, like a tumor growing or an infection as well. And so I think you're right that the normal pressure hydrocephalus is usually the slow, insidious onset of cognitive problems, urinary incontinence, losing control of your bladder, and a walking problem, where people tend to have their feet look like they're stuck to the floor. And depending on what stage you get it or what stage we find it at, some parts of it can be reversible. Yeah. I had a patient yesterday actually in clinic who we saw and had a shunt put in to relieve the pressure from the water from the brain, and she's done remarkably well.
Yeah. So definitely worth an investigation, and typically the sooner the better. Not everybody does respond to it, and people can have more than one process going on. So they may have an Alzheimer's dementia or a vascular dementia and also develop hydrocephalus. So putting in the treatment, which is usually a shunt to get rid of some of that pressure, doesn't always have the reversible effects that we might want. So there's another question that in a severe stage of Alzheimer's, is the person always bedridden, or does that vary?
Yeah, so it does vary. You're much more likely to be bedridden at the very end stages or end of life stage of Alzheimer's disease. But there are many people that have severe Alzheimer's disease. You were describing people that are kind of agitated or aggressive or things like that, where they're not bedridden. So it really depends. If somebody is bedridden, though, you always want to look for reasons why they might be bedridden. Rule out other medical problems, muscle weakness, neurologic problems that may contribute to them not being able to walk. And so you don't ever want to say, oh, this person has dementia and therefore they should be in bed. It should be, well, what stage of dementia do they have, and what were they doing before they came into hospital or came into a long-term care facility, and making sure that you don't just dismiss somebody as being bedridden just because they have dementia.
And they may have more profound apathy, so that they're less interested in getting out of bed, but that doesn't mean that there wouldn't be opportunities for staff or family members to try to encourage somebody to remain active to reduce their risk of developing other complications that come from being bedridden. So.
Well, I can actually give you two examples, which are kind of interesting from my clinical practice, where one person who came in who was bedridden had really severe undiagnosed Parkinson's disease. And so they'd never been treated with the medications appropriate for that. And then somebody else had a pretty profound autoimmune neurologic disorder, which was treated, but they came in and, oh, it's grandma, she has a dementia, she's just lying in bed, but you can actually...
So never assume that somebody should be bedridden. So. Is there early detection possible through any kind of blood tests?
Right. So there are tests for research purposes where you can check various levels of different chemicals, but nothing's been validated for clinical practice. There are laboratories in the United States and elsewhere in the world where you can send your cerebral spinal fluid, so the fluid that's around the brain, for varying levels of the toxic protein. So beta amyloid we've discussed on previous.
Do I need to say, please, none of you try this at home?
Yeah, none of us try this at home.
It's all part of research protocols.
It is, but some people do it in clinical practice in the US. We do not recommend it because they're not that accurate in terms of how well they predict what's going to happen. You showed this scan of the brain, which showed some mild, moderate, and severe changes. You can do PET scanning where they show glucose metabolism, and for certain people, you'll show decreased metabolism or uptake of glucose in those areas. So there are a few tests where we could do them, but we don't necessarily recommend them.
What we talk about in the lessons, I think a lot of this is covered in lesson 1 on sort of what is dementia, is most of the investigations that we do are to rule out reversible causes of cognitive impairment, making sure that somebody doesn't have a very, very low sodium or somebody doesn't have a vitamin B12 deficiency. There are other tests that we might do, brain imaging tests or sending samples from cerebral spinal fluid or a spinal tap. Those are either looking for other very specific causes in some rare cases or to sort of support the diagnosis of a particular type of dementia, but we don't really have a early detection through blood tests just yet, but it's absolutely an active area of research.
The other question is with those tests, it's what do you do with the information when you find it? And so we can scan your brain and look for beta amyloid in the brain right now, but we can't do anything actually. And there are people that have normal cognition which have beta amyloid in their brain, so it gets to be a bit too confusing, I think, and not actionable.
Yeah, I think for the most part in medicine, if we don't have a disease-modifying treatment, or if it's not going to change your management, then we don't usually order tests just for the sake of it. But in some cases, I think being able to support a diagnosis or rule out a reversible cause is important. So.
I think too, generally for people that are younger, that are very highly functioning, that might have milder stages, would certainly order an MRI.
Yeah.
And the MRI, from an early detection point of view, can sometimes see shrinkage or atrophy in certain parts of the brain, which may help you better narrow down which type you're dealing with or whether you think that somebody might progress.
Another question, does melatonin really help patients with dementia? And is it really true that there aren't any side effects when using this drug?
So there's no trials that I'm aware of where people take melatonin and it improves their dementia. There's really mixed, poorer quality studies on melatonin for sleep in general. So that's, we can use it. It does tend to be on the lower side effect profile when comparing it to other medications. So the lorazepam or diazepam,
the Z drugs,
Zopiclone or S-Zopiclone, or things like that, which really increase your risk of falls, increase your risk of confusion, next day hangover side effects, increase your risk of car accidents. Melatonin's relatively safe. It does have a much better side effect profile, but there are some people that are sensitive, which have bad reactions to it. So it's kind of one of those mixed things. There is reasonable evidence in people that have REM sleep disorder, where they act out their dreams, that higher doses are effective. So that would be one instance where if somebody had a dementia or a neurodegenerative illness, I would put them on melatonin to help with those symptoms. And if somebody does have some mild sleep problems and they really, want them dealt with, I'll sometimes trial them on that.
What about hyperparathyroid issues and the possibility of calcium levels causing dementia-like symptoms? And I would say yes, both hypercalcemia, where you have too much calcium in the bloodstream, and hypocalcemia, where there's too low, can definitely be associated with a range of different psychiatric or neurological symptoms. So it would typically be one of the blood tests that we check for, not necessarily testing for parathyroid levels, but we would usually check calcium levels. And if there were a problem with calcium, we would then go on to investigate.
And most people that have hyperparathyroidism have mild increases over time, and the higher levels of calcium are really where you run into problems with the cognitive issues. So there are many people, the vast majority of people, that have hyperparathyroidism with mild to moderate elevations, which really you need to worry about their bone health a lot more, or kidney stone risk, than you would ever have to worry about dementia. But if they had some sort of cancer or something that was elevating their levels of calcium to a really high level, then you'd be more likely to show cognitive problems.
Could you please clarify what was meant by dramatic decline as opposed to gradual expected decline?
Sure. So if somebody comes, and this was in the context, I think, of the hospitalization we were discussing earlier, would be somebody that was walking around independently, having some challenges with their taxes, maybe needing some reminders every once in a while to take their medications, but perhaps out on the golf course on the weekend, or really still quite engaged at family events, having discussions, to going into hospital and being not responsive, or sleeping all the time, or being very worried and very confused, and perhaps having fluctuations in that. So at some points they look good, or some points they look really terrible. I think that's a very dramatic decline. So
might be more like days and weeks with changes that are strikingly noticeable, as opposed to months and years.
Absolutely.
And as you said, sometimes in those cases, it's does the person have an intercurrent medical illness that is causing delirium or acute confusion if they're changing that fast? The other thing that is kind of interesting is, because diseases like Alzheimer's are very common, even though they're mostly slowly progressive, there are some people who do progress more rapidly with Alzheimer's.
Absolutely,
and while there are some rare causes of rapidly progressive dementias, probably still the most common cause of a rapidly progressive dementia is an unusual form of Alzheimer's.
Yeah, it'd probably be Creutzfeldt-Jakob disease, or CJD, is probably around 60% of those cases. And then out of the remaining 30%, it's kind of people don't know, it's unknown. There's an autoimmune paraneoplastic cancer-related cause, or then it's things like Alzheimer's or Lewy body dementia.
We also had...
The other thing, I forgot to mention, was just that anytime there's a rapid change like that, we always worry about a stroke, right? Something that could come on quite suddenly, often associated with other neurologic problems like weakness and problems with sensation, or changes in vision as well.
So we had a few really good stories that were sent in with other questions as well. So one of them is from a woman whose husband is at age 61, had a heart attack, and he had an angioplasty stent placed in his coronary arteries. And then since that time, he's had rapid memory loss over a 4-year period. They had a doctor that retired, a new one that didn't really check in, but the new physician has been paying attention and is doing current investigations, workup, did the MOCA, the Montreal Cognitive Assessment Screening Test. Don't know what the result was. And then there's an MRI coming up. And the question was whether there could be a correlation between the heart attack and the memory loss, which seemed to begin right after. It seems so coincidental and shocking. Any comments on that story from a caregiver?
Sure. So if somebody goes into a hospital with a medical issue such as this, and specifically heart-related issues, you'd worry whether they had a delirium at that time, and that maybe unmasks some underlying cognitive problems. The other thing that can take place is when they put a stent in, they go up around the aorta and they can knock off some cholesterol plaques, which can then go up to the brain and cause a stroke. Sometimes you're aware of it and sometimes they're silent. But the MRI should help understand whether there's been an old stroke or whether there's lots of vascular burden there. Another thing to be aware of is that some medications associated with heart diseases can slow your cognitive function. So beta blockers in particular can sometimes make people feel a little bit slower or depressed in some instances. The one thing that I would say though is, has it been rapid, gradual, progressive memory loss over that 4-year period? Or did you notice once 4 years ago that there was a rapid sudden decline and now that stayed consistent? Because that would be more consistent with, as you said, the stepwise decline of a vascular dementia or the new addition of one type of medication.
And depending on the severity of the heart attack, there are some heart attacks, but they usually occur in the back part of the heart. Right. Where they can basically the pump is so affected by the heart attack that it will deprive the brain of blood and oxygen during the heart attack. But it sounds like that's not what occurred in this case. But again, as you say, if there's coronary artery disease that led to the heart attack, there may also be cerebral vascular disease that was happening that is making the person vulnerable. And the MRI scan of the brain should be helpful to detect whether or not there are, multiple small vascular lesions in the brain as well. So we have another story about my father's 84, his wife 72, and she's been diagnosed with Alzheimer's a few months ago. She started on a medicine. Her test results show cognition of about a 10-year-old. That's not usually how we would say it, but I'm going to say probably a moderate stage of dementia. When we visit, she seems like herself, but Dad's having a hard time dealing with her, especially mornings take a lot of patience. Her mother also had Alzheimer's. He's attended a course for caregivers, so has a sense of what lies ahead. But one of the biggest problems seems to be her denial. She prevents him from speaking to anyone about it. He's feeling very alone. She doesn't want anyone to know. The father, though, has broken down when talking with brother and the person who wrote the story. How should the family approach this situation? They're trying to be supportive. They only let us come to visit for brief hours and don't want to talk about anything real or of substance. She gets upset if we try to help Dad by calling on his cell phone, although he needs the help. And they're wondering, should we ask directly how she's doing? Do we ignore the situation? How do we talk to him alone when she's almost always together at the same time? And they want to try and do this in a respectful manner. Any suggestions? This is not an uncommon, and it's a very challenging scenario.
I think it's particularly challenging when you start noticing problems and then start trying to intervene on the problem side or thinking about the negative side of what's happening all of the time, perhaps reframing it and trying to get your father out for an enjoyable activity to give him some respite, where he feels like he gets a little bit of a rest or a break, and then kind of bringing it up, because he is an individual as well, and he needs his emotional needs taken care of and needs to know that he's supportive. If you take him out and bring it up while he's not in front of his partner, then it might be easier for him to open up and talk about what the challenges are that he's experiencing. And then trying to get in community supports to try and help deal with or help navigate the system. So she sounds, like she might not be agreeable to having somebody come into the house, let's say, but certainly they can help get, the father connected with further support groups or things. I think
that I would agree with you. I think the strategy here is to continue to be respectful, but it really sounds like in this scenario, the father, the primary caregiver, needs that support. He's feeling the burden. He's maybe a bit burnt out and at risk of depression and anxiety. And so I think working, not ignoring it or avoiding it, trying to get additional community supports that can help to support the father in this case, or even some kind of a respite situation where you would go over and allow the father some time out on his own and sort of focus on his health if she's less willing to accept help. So we have another question that was sent in from a caregiver in Ontario. Husband has recently been diagnosed with a mild form of dementia, either vascular or Alzheimer's, possibly mixed. He also has a long-standing 25 to 30-year history of a severe hearing loss. And the cognitive testing has shown problems with short-term memory, processing conversations, following instructions, word recall, a lot of things that relate to speech and language issues, although I guess short-term memory would be a separate one. Is it possible that the cognitive decline is due to the hearing impairment and not at all due to an underlying dementia, either Alzheimer's? And what about that relationship? I mean, there were some more detailed questions, but what about that relationship between dementia and hearing loss?
And I mean, this gets initially to how to optimally perform cognitive testing in the first place. So one of the first steps we do is, can you hear properly? So can you hear the instructions to the test? So making sure that somebody has their hearing aids. If they do have hearing aids, making sure that the prescription for their hearing aids is up to date. If they don't have hearing aids, there's a device we can use called a pocket talker, where there's headphones you put on your ears and then an actual microphone that's connected. And if you can speak into a pocket talker or speak to somebody and they can follow all of the basic commands and demonstrate that they can hear you, then probably the challenges with the cognitive testing are not just related to the hearing itself. So that's the first important thing. I think just some other general issues are also making sure for cognitive testing that the lighting's appropriate, making sure that somebody has glasses and that their vision is corrected if they need them, making sure they've had a good night's sleep and haven't been up all night for the past 2 nights or don't have an intercurrent medical issue or things like that. So optimizing hearing is really important.
I think the other thing is that, if the hearing deficit goes unchecked or without an intervention, the person's also likely to have more social decline, a lack of social interaction, which in and of itself may, sort of contribute to further cognitive decline. So I think, there's some other interesting questions about this that, is there any change in the treatment approach if there is both dementia and hearing loss? And at this stage, it would be like, do whatever you can to optimize the hearing. And depending on the nature of the hearing loss, there could even be a role for cochlear implants potentially. But it wouldn't change our approach to the symptom treatments in dementia.
It is interesting, though, that association. So hearing loss or having reported hearing loss is a risk factor for the development of dementia. And you wonder if there's something happening in the brain with respect to processing. It's very similar to losing smell many years before the onset of Parkinson's disease. It could be a harbinger of
one of the other questions that they were asking is there any role for, say, more detailed neuropsych testing? And I would say yes. Like if you are unclear about that, repeating the hearing or audiological testing and doing everything to optimize it, but then also doing, say, more in-depth neuropsychological testing, I think would help to tease out domains where there could be cognitive impairment that would not necessarily be directly affected by the hearing loss.
It's really interesting to see those tests come back where for us it's, well, are you mild, moderately, severely impaired? But for every domain memory, it's you are on the 85th percentile of somebody at your age with your educational level. It's very helpful to be much more specific.
And in some cases with the neuropsychological testing, the person administering the testing might do a debrief and say, oh, you might find these strategies helpful because these parts of your brain are functioning quite well. So it may be a clue to some what are sometimes called compensatory strategies, things that you could do to help make up for some of the cognitive impairments. We do have a couple of other questions, but I'm conscious that we've run over because of the technical delay, and we've done a full 45 minutes. So I'm going to wrap up for now. We'll either respond to some of the other stories and questions in writing, or we'll save them for our next live event. I want to thank everybody for joining us today, particularly for the patience as we overcame our technical glitch around the live stream. We hope that we can continue to bring these live events and the iGeriCare platform to you. We're continuing to develop new content and bringing you these live events. We want to continue to bring this as a free resource to the public, and we hope that you can support our cause by donating. You can donate through our website in the top right corner of iGeriCare.ca, and your support enables us to keep bringing you these live events and updating our resources and continuing to develop new content. I want to thank all of the people that made today possible. Funding provided by the Canadian Centre for Aging and Brain Health Innovation, that's powered by Baycrest. Additional funding from the Hamilton Health Sciences Foundation, the Jarvis Centre, McMaster University, the Alzheimer's Society Foundation of Hamilton Halton, and our team, the Division of E-Learning Innovation. A reminder that our next live event is Thursday, July 4th at 1 o'clock. And our topic, a hot one, consent, capacity, and care planning, kind of ties in with some of the things today that we alluded to in the later stages. There is a survey pinned at the top of the comments section. It's really helpful for us. We get great feedback from you guys. And as always, I want to thank our great team here, especially Grace under pressure, making up for our live web stream. Teamwork makes the dream work. And we will be posting the video on iGeriCare in the next couple of days. Thanks so much for joining us today.